my focus today is new directions and paradigms with a focus, on what we call single visit approaches, often also termed screen and treat programs. And as you'll see, my thesis is that it's really the programs that are important and how programs are constructed for cervical cancer prevention, as opposed to any individual component. Now, first, I just have to be transparent and say that I am a medical advisor for mobile ODT. But moving on from that, again, I think it's important to always recognize that cervical cancer affects people when they're in the highest period of either child rearing in most cases. So it doesn't affect people in their very early reproductive years. Cervical cancer attacks people and becomes prevalent in populations in the height of those years when women are taking care of their families and their children, in addition to conducting a career and a profession. So it's an important time period, and as I'm sure all of you recognize, cervical cancer is entirely preventable. Now, in terms of progress, and I've been working on the problem of cervical cancer prevention for longer than I care to think about, but here are some statistics, and it's sort of a report card on cervical cancer versus maternal mortality. And as you can see here, over the last number of years, and this goes back probably, it includes approximately a 20-year or more period, you can see that because of investments made in maternal mortality reduction, maternal mortality around the world has decreased by 34%. It is a component of the Millennium Development Goals, MDG 5, improving maternal health from pregnancy-related complications. And one can estimate that during this period, something on the order of 12 billion, you can see it written here with a B, dollars have been spent on maternal mortality reduction. And if you look on the other side of the graph, you can see that conservatively, 270,000 women die annually from cervical cancer. So not that far apart really from maternal mortality these days. And because of changes in population dynamics, and because of the next line in this graph, that where we don't really know how much has been spent on cervical cancer prevention in recent years, but not nearly 12 billion, I would say less than a couple hundred million over these last years, that it really has increased in mortality, largely because of the lack of the kinds of programs that we're going to discuss. Now, if you look at the next couple of slides here, this is just an example of a population pyramid from Kenya. And I believe there's some participants on the call today from Kenya. But if you look at this population pyramid, which shows the various percentages of the population at given age groups, you can see that Kenya has what we call a pyramid-shaped population pyramid with a lot more people in the younger age groups than in the older age groups. And we often talk about the burden of disease and the burden of screening for cervical cancer, and many countries realize that they are really not even reaching the tip of the iceberg when it comes to screening, effectively screening an important proportion of the population. You can see from this graph here that right now, these current screening ages, which is from say 25 to 49 or 25 to 50, that this is, on the fatter part of the population pyramid, but look how much more work we have in front of us when the younger age groups, which often comprise 60% of the population, which are under the age of 30, when they start to become at an age when they need screening or are at risk for cervical cancer, we have that much more work in front of us, and therefore we have to make sure that our programs are efficient and cost effective. Now, Another caveat about programs is that over the years, especially when the pap smear first came out in the 1950s and going into the 1990s, if you were to attend a meeting or were interested in cervical cancer prevention, and most of the time in those days, people just talked about cervical cancer screening and didn't term it as cervical cancer prevention. It was all about the screening test. It was all about cytology, making the pap smear more sensitive or more specific or both. We saw the development of liquid-based cytology as part of this emphasis on making a better pap smear. But the leverage of screening, the screening coverage, and links to treatment were really either assumed to be there or they were ignored in discussions of programmatic approaches to cervical cancer prevention. However, this has really evolved in the last 20 years or so, especially with initiatives that surrounded the introduction of visual inspection with acetic acid, VIA, which we started to work on in the late 1980s and has become very popular in a number of settings. It meets a lot of the criteria for an effective screening test. It has some drawbacks, and we'll talk about that a little bit. But the point here is that programs have evolved into a much more realistic perspective on the links and the importance of the links between screening and treatment, the effectiveness of this treatment, and getting screening coverage. Now, this issue of coverage is something that I'm going to emphasize because without coverage, and we've heard about coverage really up the wazoo for the last few years during the pandemic, without coverage, you really can't affect the level of disease in the population. And I wanted to share this slide with you that I created concerning what I think are the similarities between cervical cancer and COVID-19. You know, we have a lot of tests for both COVID and cervical cancer, and there are discussions and disagreements and controversies about which test we should use if trying to assess the level of risk in the population or who's got the disease. Of course, both are caused by a virus. Then we have vaccine issues for both entities. So in the United States, for example, as many of you may realize, there have been huge discussions and controversies and anti-vaxxers, people who are against vaccinations, distrusting the side effects. And with cervical cancer, there was concern about promiscuity. But there was at least a vaccination program. That said, and many of you may not even know this at present, but in the United States, even today, only about 15% of the US population has received more than one COVID booster vaccine. Less than 60% of the US population of reproductive age or in the ideal years for vaccination have been vaccinated for cervical cancer. So again, a lot of work left in front of us. So are there coverage issues? Yes, absolutely. Both for COVID in terms of who gets tested and who gets vaccines, and also the same for cervical cancer. Are there treatments? Yes, we have treatments for COVID, especially for mild disease such as Paxlovid. And we have treatments for cervical precancer as well. But for advanced disease for both COVID and cervical cancer, treatments are not very successful for advanced disease. So these are kind of some of the similarities that we faced. And when dealing with the pandemic, it began to dawn on me these levels of similarities, and we need to approach them in the same programmatic way that we have for COVID. And what are some statistics just about the US, for example? So, and this has to do with coverage. 50% of all cervical cancers diagnosed in the US have occur in women who have never been screened. And there are a lot of women in the United States who have never been screened, particularly immigrants, people who came from a country where screening was not prevalent, or another 10% of cancers occur in women who have not been screened in the past 5 years. And this is a population of people who may have completed childbearing. They may have a long-term or a long-acting reversible method of contraception, or even permanent contraception, such as a tubal sterilization, or even a vasectomy in their partner. And they didn't feel the need to have any kind of a wellness or preventive visit. So these two groups alone, women who have never been screened, even in the US, and people who have not been screened in the last 5 years, that's a coverage issue, and that accounts for 60% of cancers in the US. So again, coverage is critically important. I'm going to show you just a couple of graphs which you may find interesting. I'm not going to go into these graphs in detail because in reality, I could spend a whole hour just discussing this graph, which is about cervical cancer incidence in the US. And actually, it's a story of changing risk factors, access, and coverage. And I've got a few arrows in this graph, which represent watersheds in time. But the most important thing I want everybody to recognize here is that it's only less than a century ago, in the 1930s, the United States had the exact same cervical cancer incidence as many developing countries do today. And in the United States in the 1930s, there was no screening, there was no prevention of precancer. So it was a really kind of disease in a state of nature. And then over the next several years, several things happened which began to decrease the risk of cervical cancer. We had a depression in the United States, which led to reduced childbearing. Reduced childbearing often relates to reduced intercourse, which is a risk factor for cervical cancer. Then came World War II. Women went to work. In the United States, when women go to work, they get health insurance, and they had more access to clinical care, to healthcare, than they did before. And it wasn't really until the 1950s that the pap smear was introduced into the United States, contributing to an already steady decline, largely because of access to healthcare among women and the pap smear, a steady decline. But you can also see here that in the 1990s, it's kind of leveled off and hasn't decreased tremendously since then. Now, I'm going to show you, many of you who are not from the US may not know this, or you may know it from watching the news sometimes, but in the United States, we tend to divide our states into red states and blue states. Typically, red states are Republican-leaning states, blue states are Democratic-leaning states. But this is about red states in terms of cervical cancer mortality, and blue states where the mortality was below this threshold of 5 per 100,000 women in the population. And you can see here that in 1954, before the pap smear was introduced, most of the United States was red. High cervical cancer mortalities. You may ask, why was this area up in the northern part of the United States blue? Well, maybe a little bit cynically, this is a very cold part of the country. It's might be too cold to actually have sex. I don't know. But it's also a very rural, more sparsely populated part of the country. If you look at the more densely parted populations on the East Coast, the central Midwest, or the West Coast, you can see that these areas weren't really any different than the rest of the country. But as the pap smear was introduced and organized screening programs were introduced, you'll see that the change began to occur slowly, but definitely. And here is 1975 and 79, 1984, 1990s now. And you can see here that by the 1990s, recognizing it took almost 40 years to get this way, we finally had a situation in the United States where almost the entire country was dark blue, which meaning a lower level of mortality. But there were still some areas, for example, in Appalachia, which is a very poor part of the United States, the southern border with Mexico, where again, a lot of women may be coming across the border who are unscreened in the past. And this part of the country in the Mississippi Valley, which is a coal mining country, and also a very poor part of the country with poor health access, so healthcare access. So I think that this is a lesson learned in how long it can take to really affect cervical cancer mortality in a positive way, and the kind of efforts that it requires. Now, the most important thing to remember in some of this is that screening or testing by itself has no intrinsic preventive value. I could do all the pap smears, all the HPV testing, all the VIA I wanted, but unless I'm able to link that positive test to a treatment, or at least a confirmatory test where it's possible, the program has no intrinsic preventive value. So for effective programs, testing must be linked to treatment in the most efficient and effective way. Now, this brings us to the topic of so-called single visit approaches. There are better linkages between testing and screening and treatment if everything that needs to happen can occur in a single visit. Now, conventionally, when we separate these visits, and you have a test, and then you have to return for a visit or get contacted about the results of your test and then come back for a treatment, conventionally, only about 50 to 70% of those who need treatment actually get it. And I'm going to show you an example of that in just a second. But with single visit or screen and treat approaches, it's been well documented that 80 to 95% of those who are determined to need treatment or who should be offered treatment get it. So this also means that if a patient is screened and even a suspect cancer or a very advanced precancer is identified, then there are better linkages on that single visit when referral is needed and more advanced treatment is required. So if at all possible, we want to do this in one visit. And these days, I think there are more than one approaches to such a single visit approach. And this is, I'm showing you this slide, which occurred, a study which occurred a number of years ago already, but the people in San Diego, California, they called this the single visit program. And what they did, they arranged in their hospital to get pap smears obtained on people, and many of these people were undocumented or immigrants to the US near the Mexico-US border. And they arranged to have the pap smear performed and read within about 30 minutes. So that when 30 minutes after having the pap smear obtained, the woman could get the result. And these were all emergency department visits. And what you can see here is that the pap smear showed, if the pap smear showed high-grade disease or atypical glandular cells, 88% of the people who needed treatment were treated if they were randomized to the single visit arm. But if they were randomized to the usual care arm, which means they were sent away without knowledge of the pap smear result, and they had to make an appointment or were tried to be contacted for a return appointment and potential treatment, only 53% of those people actually returned for a visit. And these are the people, or got treatment rather, these are the people for whom it's most important that we provide treatment. These are the people who are on the doorstep of, or potentially on the doorstep of invasive cancer. So again, even with cytology, which I think is of mainly historical interest at this point, even with cytology, if you can do that pap smear and do a single visit, you have a more effective program than what we've been doing. So how can we improve the effectiveness of the single visit approach? Well, what we really have to do is turn exploration visits into solutions visit. An exploration visit is the typical doctor-patient or healthcare provider-patient interface where I might come to my doctor and my doctor does an exam or takes my history and then says, okay, well, we're going to get a bunch of tests, maybe including an HPV test or a pap smear, and sends me home after having done the test or sends me to the lab to have blood drawn or whatever it is. But then I have to make an appointment again, or the doctor has to contact me in order to decide what our next steps are. So the first visit was really an exploration visit. Let's see what's going on. What we really need to do is turn these into solutions visits so that in the very same visit of test taking, we can find a solution, whether it's referral or whether it's an immediate offer of treatment. And this concept of solutions visit is what I really want to emphasize in this whole concept of the single visit or screen and treat approaches to cervical cancer prevention. Now, we have a number of tests that can readily be employed these days. There is the Pap smear, the Papa Nicolau smear, cytology testing, but this is among the most complicated, and I think in today's world, the least cost-effective and also the least programmatically effective because of the length of time that it takes to get results and the level of infrastructure required to get a result back to the doctor or back to the healthcare facility and then back to the patient. And it's been well beyond the means of most developing countries for quite some time. Visual inspection with acetic acid, which is the term we coined in about 1999 in a paper published in The Lancet, it's relatively easy. It does require a speculum. It does require some training and some continued training to make sure that the person doing the test is seeing what we want them to see. And it's true that it's a subjective test, but in many ways, so is the Pap smear. It's a subjective test, and beauty, if you will, is in the eyes of the beholder, in this case, the healthcare provider. But it is simple and it's very affordable. It can occur in a single visit. It doesn't take very long to do, as most of you, I'm sure, know. But it's the subjectivity and the variability in both sensitivity and specificity that makes it perhaps a less desirable test if we have something that's more objective and more readily available to offer. That brings us to HPV, which has been in the wings as an important test for a number of years now. And I think many centers are moving now to a self-swab. And one of the questions that still remains is the cost and the price of the test. In many locations, the cost, or at least the charge for an HPV test, is still beyond the means of what many countries or programs can afford. But the cost is coming down, and it will come down further in coming years. Whether or not, and the machine that's required for analyzing the HPV test have also become much simpler and easier to manage, and also much more portable, even to the point of an antigen test, just like we have for COVID. You might actually call that a COVID dividend for HPV testing. So in the future, I believe, and I think many of my colleagues believe, that the initial test that we'll be performing is a self-swab, or I'm going to share another approach with you in a second, a self-swab or a conventionally collected swab, a clinician-collected swab, which can be performed. The test can be run in about an hour with one company's technology for about $1.50 or so per test. If you look at HPV testing in a little bit more detail, it's increasingly approved as a primary screening approach. For example, in the UK and Australia, there is now one test approved for this purpose in the USA, and other companies are standing in line waiting to get their tests approved. We've been involved in a study of the test of another company at Stanford, which they're going to be submitting for FDA approval as a primary screening test in the USA. But one of the challenges is that it still can be laboratory intensive. And what are the chances of really having a true point of care test? Now, many of you who work in mobile or itinerant settings may already be familiar with programs such as the Amplifier test, Attila Biosystems, for example, which can run a test in about an hour, relatively inexpensively, with a very mobile machine, and it works very well off a self-swab. But what I also want to share with you is that the PCR cycle threshold, this is the time it takes for the standard PCI test to become a window, to become positive. So this threshold, and this is the number of cycles on the PCR machine, polymerase chain reaction machine, the number of cycles it takes to become positive can be a window into what the likely histology is. So it's possible that despite the fact that HPV testing often has a somewhat only a moderate specificity. By making use of this PCR threshold, we can better understand, or we can better predict who might benefit from colposcopy or an offer of treatment. Because as you can see from this slide, when this patient, this line here this is a patient who had high-grade disease, her test turned positive for 16 in about 12 or 15 minutes. Whereas you can see in these patients who had CIN1, which is just basically an indication of HPV infection, it didn't turn positive for about 25 or almost 30 minutes. So by doing a little bit more research, which we're actively doing at Stanford now and in other places, we think we can establish a threshold through which, if the PCR is not positive within a certain number of minutes, the likelihood of there being high-grade disease is lower. And this would reduce the number of people who might actually need a colposcopy, or who might need to be offered treatment. Now, another approach that's receiving an increasing amount of attention, even in developing countries, is uses of menstrual blood. This is actually the emoji for menstrual blood. Many of you may be surprised that menstrual blood has an emoji, but it does. And this emoji and menstrual blood is, as I said, of increasing interest in this domain. This was a study that we did at Stanford not too long ago and published in the Journal Obstetrics and Gynecology. And we compared the results of a menstrual blood test using a specially developed pad, which I'll show you in a second, the Q pad. And this was versus clinician collected specimens. When there was severe dysplasia present, the Q pad, or the menstrual pad, was 100% in agreement that HPV was present compared to the clinician collected swab. And in general, there was about 95% agreement between anybody who had high-risk HPV on the clinician collected swab on the Q pad. So that's very good. And it was a higher rate of correlation than with the self-collected swabs. So the menstrual pad here performed a little better than the self-collected swab. And what was interesting was that 94% of patients, this is not surprising, preferred to have their test done via the Q pad or the menstrual pad compared to a clinician collected swab. And even at Stanford, there were about 23% of patients who refused to do a self swab because of their discomfort with the procedure, but did proceed with use of the Q pad. So this is a very promising approach. And as I mentioned, there is global interest in this. And I'm just showing you the top lines of various papers that were published from China, Korea, and India, using the menstrual pad as a cervical cancer screening tool, or looking at feasibility and accuracy in India, the same thing in terms of Korea. And all of these papers show about a 95% correlation or so between cervical cancer, between HPV on the swab and HPV from the menstrual specimen. So, excuse me, this is an area of, I think, intense and promising interest, and very much can turn these explorations visits into a solutions visit, because the patient could send in the specimen from the Q pad, which is shown here. There's a little strip that's embedded into this pad, and you just remove the strip. This becomes a dried blood spot. It's not a hazardous material, and you can send that to a lab or to a clinic, or bring it to the clinic and have it analyzed, so that on the day when we might be having a camp or an event for cervical cancer prevention, we would already know the result. Now, in terms of diagnosis, we also have a number of advances, many of which you're probably already familiar with, in terms of a smart digital colposcope based on a mobile phone. The most recent version of this is the EVA Pro, which is manufactured or distributed by Mobile ODT. And here's what the device looks like if you haven't seen one up close and personal yourselves. It has a lens system with a built-in light. a magnification, the potential for a green filter. You can record the image. There's software that allows you to create a report. You can send the image to a medical record. You can also send the image. You can, for those of you who ever watched the Who Wants to Be a Millionaire show, you can phone a friend. You can send this image to an expert, maybe someplace else in your region or in your country or in your town, and they can commune with you on what they think is going on with this image. Now, the images that the EVA Pro takes are really astounding. We have one of these units at Stanford, and it has become the go-to colposcope for our clinicians at Stanford. Now, perhaps looking at these images in this presentation don't do the images justice compared to what you actually see in real life. But these images are really very, very vivid and detailed. Here you can see a lot of mosaicism in this patient here. And on this side here, if I was to enlarge it post hoc, which I can't do in this presentation, again, a lot of mosaicism, ceto-white lesions there, some gland openings and so forth. So it's really a first-rate colposcope with all the advantages, especially relating to mobility, recording the image, software enhancements, and so forth, and a green filter, for example, for those who want to use a green filter, as any other colposcope, but at much lower cost and much more mobile and portable. The other really cool thing about this approach is that there is an AI or artificial intelligence component, which can be available, not at the present time on the EVA Pro, but on other mobile ODT products. This is called Visual Check, and it's a computer-aided diagnostic tool. And what the computer aid does here is will show here's the cervix before the computer was asked to analyze it. And here's the image where the computer has shown us using what we call a heat map, where red indicates the likelihood of a lesion being present. It shows the lesion present. And in a recent study conducted in Poland by Dr. Grzegorz Glab, presented at Urogyn in 2022, with biopsy backup for any of the patients who had discordant results between what the colposcopist thought and what the visual check said, there was a sensitivity of 92%, a specificity of 79%, call it 80%, and a Youden index, which is really a measure of the total accuracy or receiver operating characteristic curve of about 77%, or if this was a kappa statistic, 70%, 77% would indicate substantial agreement between the two tests. To me, this is a really exciting development, and I think is part of the future of cervical cancer prevention, because it allows almost anybody to have an angel sitting on your shoulder, whispering in your ear, and we can get this result back in about 60 seconds by sending the image to the cloud, having the computer analyze it and send us a result back. This is really exciting to me and may eventually obviate the need for biopsies if we can show this kind of sensitivity and specificity for high-grade disease and above using computer-assisted diagnostics. Now, and I'm just going to show you what really happens in real life. Here's an image that was taken by the machine, and we sent it up to the cloud, and it comes back that the cervix is abnormal, and I'm sure that most of you would agree that this is not a normal-looking cervix. So if I'm not an expert colposcopist, or maybe I'm an outreach worker doing a program, this could be of tremendous assistance. Here's another image. To me, again, this looks like a pretty normal cervix. And the computer gave me a result in about 60 seconds or so that it was normal. So I think that this is to me is a really, really exciting development. And I look forward to more advances in this connection in the future. Now, what about treatment? Because all this time I've said, well, we have to link testing and treatment. Many of you may be familiar with cryotherapy. Cryotherapy was the mainstay of treatment for cervical precancer in the 60s, the 70s, even the early 80s, until excisional loop technologies came along, LEAP or LETS loops, loop electrosurgical excision procedures, LEAP. But since cryotherapy started to be implemented in many countries where we were doing VIA programs and now HPV programs, there were a lot of drawbacks to cryotherapy, especially the need to have a gas supply. And CO2 prices, carbon dioxide prices, just like every other price in the world, has gone up a lot recently. And nitrogen oxide prices have also gone up. So it began to be clear that cryotherapy for many programs that were going to be portable or mobile programs, or even more rural programs, cryotherapy was not going to really do the trick. And this led to the advancement of thermal ablation. It's been called other things over time, cold coagulation, although I could never understand why it was called cold if we were applying heat, but sometimes you don't know, or sometimes thermal coagulation. But I think the term that everybody has settled on now is thermal ablation. This is an image here of what's called the Thermoglide device. It's extremely simple. It applies thermal or cold coagulation or thermal ablation. It's an approach very similar to cryotherapy, but takes much less time than cryotherapy. It takes about a minute, 2 minutes max to provide treatment to a patient. It's very portable. I mean, this is basically a handheld device that's extremely portable. There's no wires, there's no cords. It runs on the standard 9-volt battery, the kind of battery that you would use in your, you might use in your electric drill at home or something. You can do dozens of cases, and this is true at Stanford as well as any place else, dozens of cases on a single charge of this battery. And it takes about a minute even to do a double treatment. The side effects are very similar to cryotherapy. And this is just a close-up of what this device looks like. This is the control panel. It's really just a one-button approach to getting the heat turned on. Then you apply the tip to the cervix for someplace between 20 seconds and a minute or so. And what's very exciting to me about this technology is that the so-called 75 millimeter rule no longer applies. Now, we used to say that if, especially with cryotherapy, that if the cervix was going to be more than, if the lesion was occupied more than 75 millimeters, that you shouldn't use cryotherapy for this approach. Well, that doesn't really apply with thermal ablation because it works differently than cryotherapy. It doesn't spread to the same extent as does cryotherapy. And when we invented that 75% rule in the early 90s, the late 80s, the early 90s, we actually, it was because of the potential for spread to the vaginal wall that we initially developed this rule for. But with thermal ablation, that rule doesn't really mean anything because the treatment is very localized, and you can treat multiple locations on the cervix with either this flat probe or the probe that has a little nipple on it without any worry about spread to the vagina. If the lesion extends deep into the canal, then it's still not advised for treatment with an ablative treatment such as this one. Now, I will just say that before I move on to other treatments, that one of the nice things about this treatment, and the same was true for cryotherapy as well, is that it can be used to treat cervicitis. It's actually a very good treatment for cervicitis, as was cryotherapy. I still use it I use cryotherapy or now thermal ablation to treat cervicitis at Stanford. And in a number of countries, it's a time-honored approach to the treatment of chronic cervicitis. And it's really about the best treatment for cervicitis there is. And so there's a double use for this instrument. One of the interesting things that I noticed over the years was that when VIA was false positive, the most common reason was because of cervicitis and an inflammatory looking cervix. And if in a single visit approach program, someone decided to treat the cervix that really didn't have precancer, they were likely treating a cervix that had inflammation. And so it likely did some good anyway, because as I mentioned, it's a very good treatment for chronic cervicitis. Now, standing in the wings, there are other novel treatments in development, one of which is trichloroacetic acid, TCA, which we have used on the for warts on the labia and the vulva and perirectal for years and years. And it turns out that this can be a very effective treatment for dysplasia as well. It's pretty cheap. You can do this in a single treatment. It's applied by a clinician in a simple setting. These are pictures of what happens after the application of TCA to the cervix. And as you can see, it looks like a lot like a cervix that's been treated by cryotherapy or thermal ablation. And then 8 weeks later, you can see that it's healed. But the results, when there was high-grade disease present in this study from Vienna, Austria, was almost 90% regression and about 80% remission, which is pretty darn good for a single application treatment of a very inexpensive medication. Artemisinin, which is an anti-malarial plant, is also being researched, as are other biologicals, and they're less far along on the development scheme. But these are potentials for, again, low resource settings or lower middle income countries. Although I have to say that with cryotherapy, with thermal ablation, the expense is mainly upfront. The electricity that you need, the cost of electricity to provide care using this battery is negligible. And these probes, which come off and can be cleaned separately, are pretty robust. Now, so here's the dream sequence. And this is the final thing I was going to tell you about with respect to testing. And that's this HPV Stealth Test, or it could be done in a clinic. It's one of those COVID dividends, as I mentioned before. So we have an antigen test, which is for HPV 16 and 18 based on the E6 or E7 and oncoproteins. And in one study reported on the package insert, when compared again to a clinician-collected swab, it had 93% sensitivity, 91% specificity. So again, pretty similar in terms of accuracy to a clinician-collected swab. The result is available in about 10 minutes. And the procedure, again, is very, very similar to what we've all become accustomed to during COVID. We are about to implement a study in Tijuana, Mexico, where there are large immigrant populations, largely from Haiti, from Venezuela, from other parts of Central America, even from Ukraine, which may not surprise many of you, who are in refugee camps in Tijuana, Mexico, near the US border. And we're going to be running a program where we're going to be testing people with a test similar to this one, with very rapid results available to us. If the patient is negative, we will proceed to advise them to get repeat screening in 2 to 5 years. But if it's positive, we will be standing by with an EVA device, a mobile ODT device, with which we can do visual check, because most of the healthcare workers in this setting are either nurse practitioner level or general practitioners, and they will have the angel sitting on their shoulder to give them advice on what the computer thinks is going on with any given cervix. We're going to be studying learning curves. How quickly do they adapt to this technology? And then we will have a thermocoagulation unit stand by for anybody who we think is at risk, whose tests indicate thermocoagulation treatment is indicated. So this is kind of a dream sequence. This is a single visit testing, treatment, and even confirmatory testing in a single visit. And we expect the throughput for this, especially if we can do these tests before the patient even comes to clinic on a given day, so that we have solutions visits already set up, then we think this will be a very effective and efficient and cost-effective program. So I think that I'm going to just provide a few conclusions here. Cervical cancer prevention paradigms are going to radically change in the next several years. They're already changing. Molecular technologies such as HPV and proteomics will dominate as the primary screening approach. Alternative sampling approaches such as self-swabs, menstrual blood may replace conventional approaches, and already are, such as cytology. Computer-assisted colposcopic technologies will likely play an important role in these transitions in the coming years, and a variety of lower-cost treatments, such as Thermoglide, thermal ablation, and others, will become available or already are available in the next coming years. So with that, I want to thank you for your attention. I'm actually speaking to you this morning from Santa Fe, New Mexico, which many of you think may be in the desert Southwest, but no, we have a lovely winter here. I encourage you to visit, bring warm clothes, and I'm happy to answer some questions if there are any in the chat. Thank you again very much.
Hi, Paul, thank you so much for the great presentation, really thought-provoking. We are getting lots of questions. You're welcome. We have now 10-15 minutes left for Q&A. You're welcome to type your questions in the Q&A tab. In the meanwhile, we have a few questions received already, which I want to ask Paul. So the first question is that we received ahead of the webinar. What is the attitude after a conization for CIN3 and the proximal or affected margins? A, salvage conization. B, follow-up in 3 to 6 months and colposcopy.
So if I understood the question correctly, what does one do when you have a conization? And in this case, I don't think it really matters whether it's a cold knife conization or a thermal conization, such as with LEAP. So if the margins are positive, I think it really depends on what the level of disease on the specimen side of the biopsy is. If it's high grade or there's even suspicion of invasion, then I think a salvage cone has to be performed, if not a hysterectomy, if that's, you know, the best option for the patient. But a salvage conization or repeat conization, probably cold knife. But if the margin is only minimally involved and the evidence of margin on the specimen side that's been removed indicates lower grade disease, or at most CIN2, given the process of healing and repair and a patient who's not going to disappear on us, I think that we can wait a few months at least till the cervix has healed, repeat our testing. It would probably not be HPV testing, either repeat colposcopy with biopsy, or at the very least cytology, and assess the patient that way. I hope that answered the question.
Sure, thank you. Another question that we have received: how important is the contribution of liquid-based cytology in terms of diagnostic power of the test?
Well, not to be dismissive, there are certain advantages to liquid-based cytology, but I personally, and based on the data with which I'm aware, I don't think it has been a sea change in the ability of cytology to adequately screen people. First of all, liquid-based cytology is often not available in the settings in which it's needed. It might be most useful, which is in lower resource settings, low middle income countries, et cetera. But I have a colleague who used to work at the CDC, the Centers for Disease Control and Prevention in the USA, who said, you know, all things being equal, not one life has been saved with liquid-based cytology because of the lack of sensitivity overall still. Even it's more sensitive than traditional or conventional cytology, but also that the lack of a linkage between testing and treatment.
Okay. Thank you so much. Another question is about Thermoglide. The question is, do you need anesthesia for a treatment with Thermoglide?
Good question. Do you need anesthesia for Thermoglide? The short answer is no. Now, when we first started using Thermoglide, and mind you, we never gave people anesthesia for cryotherapy. We didn't give any anesthesia for that. When we first started using Thermoglide, I was just a little bit nervous myself that maybe if it's heat, the patient may be more uncomfortable. So for the first some cases, I actually provided some lignocaine or lidocaine into the cervix, and then did the procedure. Patient felt no pain. Then I did another small series of cases where I just injected some lignocaine or lidocaine, xylocaine on the anterior lip or maybe the posterior lip, did the procedure again, no pain. And now I've just become accustomed to not providing any anesthesia to the cervix at all. The patient should be counseled that she may feel some warmth, she may feel some cramping, but she will not feel pain per se, just some cramping and the sensation of heat in the same way that patients with cryotherapy felt cold and also a sensation of cramping.
Okay, thank you so much. Another question, in a situation where there is availability of colposcopy and not so many patients like on private practice, could we use the colposcopy for screening as on VIA and treatment if indicated, or is it must to use the screening test first? So what should be the order?
Well, that's an interesting question. The colposcope existed before the pap smear. The colposcope was actually developed in the 1920s and the 1930s, around the same time as the pap smear was first being developed. But the colposcope actually predates the pap smear. And Dr. Hinselmann, who was German and was responsible for the invention of the colposcope, he intended to use it in that way, as a screening tool. And it can be used as a screening tool. In fact, I often say to companies with which I'm working for family planning research, because they want to make sure that the patient has a normal pap smear before the patient can be entered into a study on a new method of birth control, they say the pap smear has to be normal. And sometimes I say to them, well, wait a second, do you want a normal pap smear or a normal cervix? Because I can do colposcopy and tell you that the cervix is normal. Now, the problem with using colposcopy in a setting like this, and I'm speaking now, especially looking into the future, is that when you do colposcopy, 100% of your patients have to get up on a table and have a speculum inserted and have a stranger with a telescope looking into their vagina at their cervix. Believe it or not, patients don't really like that. In fact, the dentist and the gynecologist are the most unpopular doctors when it comes to being examined. So yes, you could use the colposcope as a screening tool, but it's not very efficient, and it's probably not cost effective, although I recognize you don't have to charge anything to do a colposcopy. But the real issue for me is it's just not efficient. Nowadays with HPV testing, and in a study that we did in Thailand, we did mobile HPV testing. So we had the answer for all the patients that were attending clinic that day by about 11 in the morning. And then the patients who were negative, which was 95% of the patients in this particular population were HPV negative, they didn't need anything. But if I had done colposcopy, I would have had to do colposcopy on 100% of the patients, which would have been time consuming, uncomfortable, and invasive. So I would opt for a test such as HPV first, eliminate the negatives, then do colposcopy if you think you need to do it.
Thank you so much, Dr. Blumenthal. I think it was an amazing session. We got so many thank you messages. I even didn't have time to read them out, all of them, but really a lot of people are thanking you and share, that the information is super useful. There were numerous requests to share information about the Thermoglide, about the HPV test. We'll reach out to you via email and provide this information. Also, this session is recorded, so we'll be sharing the recording. If you missed part of the webinar, you will get the recording and you can listen to that afterwards. If you have any questions, we'll email you. You are welcome to get back to us, with any questions. Either we'll answer them or refer them to Professor Blumenthal. We were so pleased to have you all in this session. It was wonderful. We'll be organizing more educational webinars. Thank you for joining us and have a good day.
Thank you,
so much.
everybody. It was a pleasure. Bye-bye.
Bye-bye.